Hi friends, this is fifth session of our discussion about COVID, and it's a very important session because it is going to deal with very controversial and very hurting aspect of this pandemic. What is hurting here is worsening after intubation. All intensivists, they expect the patient to improve after intubation, irrespective of cause in majority of cases. But here opposite is happening. After intubation, patients are worsening. So we're afraid to intubate. Sometimes we end up intubating late. And what happens is that unless until we go to the root cause of this particular worsening after intubation, we won't be able to find the solution. There's no point of being in denial because almost all the patients who are expired in this pandemic, they are expired with tube in mouth. Endotracheal tube has been placed and the outcomes are poor. Whatever HFNC we do, whatever non-invasive support we do, a significant part of these patients, they ultimately require intubation. And after intubation, they go for hypotension, shock, and gas exchange worsens. Very difficult to revive. Some patients worsen early, some patients improve from that, only to worsen after some time because of renal failure or myocardial infarction. So let us go for, rather than being in denial, let us accept our drawbacks and try to find out the cause. How to accept? By using actually a real life scenario. Here we are going to discuss one case of a 10-year-old child which we lost. And while analyzing this case, we came to know what are our drawbacks and what is the scope for improvement. So let us see this particular scenario here. So here we got one baby or child, 10 years old child, complaining of fever, and then facial swelling, some confusion, and sudden development of squint. Initially, we thought it is more of a neurological issue. So this patient was admitted for actually CT scan of brain. But instead of CT scan of brain, we ended up doing CT scan of brain and lung both, and this was the picture. How the baby worsened. Initially, this baby did not have any hypoxia. Only mild tachypnea was there. And oxygen was given, tachypnea worsened, we intubated, and transiently improved. Ultimately, again went for CT scan, came back, again worsened, and we lost the child. So, rather than going for explaining this on only disease progression, we try to analyze it retrospectively. This is the classical picture of COVID. Now this COVID is affecting lung, but in this baby, we got neurological manifestations. So retrospectively, it was related with CO2 buildup. CT scan of brain was normal. Transient CO2 buildup was causing majority of these abnormalities. And we lost the child because of cardiorespiratory compromise. So when we analyze this case backward, we came across three loopholes or three turning points. What was the turning point number one? First of all, this patient came with mild distress without hypoxia. Saturation was 95% in room air, but baby was having tachypnea. This patient was given oxygen without FiO2 monitoring just because he was having distress. Now, oxygen should not be given when there is no hypoxia. But oxygen was given because of distress only. And it was free flow oxygen. After that, within half an hour to 1 hour, we got worsening of respiratory distress and hypoxia started now. Now, after oxygen, hypoxia should be prevented or improved, but opposite happened. Hypoxia started to worsen. So worsened so much that baby became distress and hypoxia. Remember, initially he had distress without hypoxia. Now he's having distress with hypoxia, worsening distress. So decision was taken to intubate this child. We intubated, ventilated with 100% FiO2. We kept the ventilator ready, settings were fixed, tubing were ready, intubated, and attached. To our horror, this patient went for hypotension. Saturation from 65-70 jumped to 90-91. And then patient started to have shock, hypotension. This shock was partially responsive to inotropes. We gave inotropes, drugs. After that, shock recovered. Saturation also slightly better, but still borderline. Now we struggled with this patient and somehow we were able to stabilize this patient. Third turning point happened. Now this patient right now on ventilator, FR2 we managed to bring down to 60%, saturation is 94%, shock was almost stabilized with high dose of inotropes. At this point of time, we thought whether problem is in brain or problem in lung. So we shifted the patient to CT scan. And CT scan by shifting, we had to disconnect the patient from ventilator, put the patient on ambu bag, and we had to bag. We observed that bagging was very easy. Throughout this particular course, bagging was very easy. It was easy to inflate and deflate. Not much of pressure required. Pressure required on ventilator also was very minimal, but saturation was problem. So this patient, once you put on ventilator, ambu bag, ultimately we had to give oxygen, free flow, along with reservoir. So in other words, 100% effort. Patient developed shock resistant to inotropes. When the patient came back from CT scan, he was in shock. And very soon he developed very severe hypoxia, shock difficult to correct. Ultimately, patient developed cardiac arrest and we lost the patient. Now, when we started to think on that, two possibilities came in mind. First possibility is whether there are any loopholes or whether disease was progressing so rapidly. We came across three loopholes, three turning points. One is patient was given oxygen without FR2 monitoring. FR2 monitoring is must in almost all cases of oxygen administration, but is not practical. Majority of oxygens are actually given without FR2 monitoring. We can't help that. Here was the key. Patient was intubated, ventilated with 100% FR2. This 100% FR2 was not essential at that time. 100% FR2 was given to this patient. Third problem was while shifting to CT scan, this patient was shifted to ambu bag with 100% FR2. So every worsening was preceded with 100% FR2, 100% FR2, and without FR2 monitoring. We doubted whether this is related with oxygen. Still, there was two possibilities. Whether the disease was progressing so rapidly that a good patient became bad patient and expired so rapidly, or there was some unknown factor. As a doctor, usually we have to be analytical and critical about ourselves, that we should find out whether any unknown factor from our understanding of the disease is responsible for this worsening. And I'm sure this sort of worsening is happening all over the world. Patients come with moderate distress, we give support, they worsen. To avoid worsening, we intubate, and after that we have disaster. That's why we are sometimes afraid to intubate, we intubate late, still disaster. So practically speaking, these intubated patients are faring very poorly. And even if you try to avoid intubation, ultimately intubation is required. And that intubation worsening, if you prevent, then I think this battle against COVID can be won. So let us go for this discussion in two phases. First phase is about only physiology and clinical. And second phase will be about investigations like HRCT, echo, plus autopsy finding. In today's discussion, we'll stick to only clinical and physiology. Physiology-based clinical, clinical-based physiology. And we'll try to find out whether we can do something to prevent this sort of worsening. When we understood and when we took precautions, then our outcome started to improve. So what is this physiological basis behind it? Physiological basis behind it is something related with gas exchange. We know that gas exchange happens in alveolus. Now we are going to see so many figures out of it. This is an imagined figure. That is this blue blood, deoxygenated blood coming from right ventricle, creating this capillary plexus, getting oxygenated and going back to left ventricle. This is not true. This is inaccurate figure. Because it is shown that only capillaries are in contact with alveolus, capillary alveolus. That's all. This arteriole or artery is not in contact. That's why it is wrong. It is a wrong figure. Right figure or right depiction is this one. What is right depiction here? Here we can see this blue blood is coming here. It's a big artery. It is going to another big artery. Then it is giving rise to other capillary. But there are a lot of places where this big artery also is in contact with alveolus. This is very difficult to imagine, but this is very crucial for understanding of this phenomena of COVID. So I'll repeat, pre-capillary artery. the pre-capillary arteriole in direct contact with gas exchanging unit, that is alveolus. So at what point the problem is happening? So for analyzing this one, we have to see differentiating patterns of tracheobronchial tree and pulmonary vasculature. This is typical tracheobronchial tree. They divide very faithfully, regularly, and dichotomously. Faithfully means what? They divide at regular interval in the same fashion. Dichotomously means what? 2. 1 gives rise to 2. So this one figure, 1 gives rise to 2 always. So trachea will give rise to bronchi, then bronchioles. So this dichotomous tree is characteristic of division of airway. Now each division is called generation. Next type of division is this. This is not division actually. It is like a river bed. We can see this is river bed. So this river bed means this faithful regular dichotomous division is not happening here. Here all these tributaries of river are coming together in irregular fashion, non-continuous fashion, and then forming a big river. This is typically seen in pulmonary vasculature. Pulmonary venous side also, pulmonary arterial side also. Now you can see this is not called generation. This is called as order. This is first order. This is second order. Then second order. Then third order. We can see this third order is not joined by second, but is joined by first order. So what are the implications of it? Why is it important for understanding COVID? It's important because it will give a basis of physiology for understanding this worsening. There are 23 generations of airways. There are 17 orders of vessels. Your message from here is very simple. Large artery can be in contact with small airway. This large artery not necessarily with large airway. Large artery can be in contact with small airway, and small artery can be in contact with large airway. So this will give you a basis behind understanding the gas exchange, particularly in COVID. What happens now? Now here is the figure again, where we are getting this deoxygenated blood. This is large artery, again large artery. This is giving capillaries. Now this pre-capillary arteriole, pre-capillary artery is the point where the majority of problems of COVID are happening. How can you say? Not only we were so sure, not only we are sure, we are actually confident about the location also. What is this location? Location is 2.5 millimeter diameter. This diameter, when the diameter is 2.5 millimeter diameter, at that point vasoconstriction is happening. How can we be so confident? We are confident because of a study. HRCTs have been done and they are actually delineated completely what is the distribution of blood volume at different diameters, different cross-sectional areas. And that study we discuss in next session. But for the time being, we can see that now we are very confident where the constriction is happening. That is at 2.5 diameter of this vessel, that is pre-capillary pulmonary artery. Now here we have to go in detail about what happens to this pre-capillary pulmonary artery. This is hypothetical airway. This is hypothetical alveolus. Alveolus contains alveolar oxygen, which is being given from outside, either spontaneously or by ventilator. Now this is pre-capillary pulmonary artery of 2.5 millimeter diameter. Here, this deoxygenated blood is coming, getting oxygenated, and going out. Now in this artery, there is a sensor. This sensor is nothing but mitochondria. Mitochondria are the sensor here. This sensor will sense two things. This sensor will sense oxygen in alveolus. This sensor will sense oxygen in blood. Oxygen in blood also will stimulate or not, or oxygen in alveolus also can stimulate this sensor. Now what is the function of this sensor? This sensor will tell the muscle to constrict or to relax. Depending on that, vasoconstriction or vasodilation is happening. So let us see what happens when COVID is progressing. COVID progresses and then improves. So what happens at the cusp? What happens at the turning point? We'll see. So what is happening now? This COVID is progressing. What is happening first? Alveolar collapse is happening. Alveolar oxygen is coming down. Once this alveolar oxygen comes down, then this particular sensor is stimulated, and this sensor tells us to constrict. This leads to vasoconstriction here. Now this vasoconstriction is happening because of this. At this point of time, arterial oxygen is normal. So arterial oxygen is normal, alveolar oxygen is less, but is already starting constricting. Now what happens next stage? Next stage is further. It is now arterial oxygen also is less. Alveolar oxygen also is less. Both of them telling the same thing, that is constrict, constrict, constrict. Now we get widespread pulmonary vasoconstriction. The previous one was local, but now it is widespread all over the lung. The COVID can be lower lobe, but this constriction is happening all over the lung. Now if you compare these three figures, you'll come to know the size of this arteriole. The size of this arteriole is quite big here. And now what is happening? As the hypoxia is progressing, it is becoming smaller, smaller, further small, because of two factors, that is alveolar oxygen as well as arterial oxygen. Now what happens when we start administering oxygen to these patients? Once we start administer oxygen to the patient, then alveolar oxygen goes up. This alveolar oxygen goes up. This tells the sensor to actually act in opposite way. That is vasodilation. I will repeat. Oxygen is administered, oxygen alveolus increases, vasodilation happens. Now, at this point of time, the PaO2 is not actually become normal. It is still low but borderline. Now, here is the catch. This sensor has to listen to two things. This sensor has to listen to oxygen in blood and oxygen in alveolus. It is like our poor houseman or registrar in hospital who has to listen to two bosses. One boss is telling you to go right side. Second boss is asking him to go to left side. Whom to listen? When there are contradictory commands, contradictory signals, whom should we listen? Both bosses are equally powerful. Then what happens is that the boss which is near you, that boss is usually followed. Somebody is actually shouting near you, somebody is shouting from phone. Usually the junior person listens to person who is near you. Who is nearer? Here when we analyze this thickness of this gap between this and this is in reality is very, very small. It is to the tune of only 0.2 micron, and thickness from the smooth muscle to the blood is almost 2 micron. So this is nearer than blood. So this sensor listens to him and it goes for dilation. Next stage comes up is rapid rise in PaO2 also. This oxygen also rises. Both of them telling the same thing, further dilatation. Now, unfortunate event happens is that this is dilated vessels accommodating large amount of volume. They have to ultimately pump into left ventricle. Now, simultaneously, left ventricle is also failing. When left ventricle is failing, it leads to huge dilatation. So now we can see this particular unfortunate patient. What happened is, here there was very severe vasoconstriction. Now what happened? Oxygen given, and one by one, it became massively dilated. Dilated, dilated, massively dilated. Now this dilation is nothing but flooding of the lung by blood. There is a reperfusion flooding of the lung. Now this reperfusion flooding of the lung itself causes a lot of consequences. What are the consequences? Ideally, blood should keep on circulating from systemic circulation to lung, the lung to systemic circulation. Now here what is happening? Blood is flooding into lungs. This is happening, but this is happening very slowly or poorly. Net result is there is actually imbalance between circulation. What happens here? This is hypothetical. Systemic blood volume and lung blood volume. And now what happens? Systemic blood volume contracts, this expands. So we get a double problem. We get a situation where too much of blood in lung, less blood in body. So nothing but hypotension, shock on one hand and bad lungs on the other hand. This is how we lose majority of patients. So what are the consequences of it? Reperfusion flooding of lung leads to hypoxia again. Initially, saturation came up, but now saturation does not recover at all. Whatever you do, this saturation does not pick up. And it leads to acidosis. This is a respiratory acidosis. Systemic hypoperfusion. Now, blood volume is leaving the system. It is going to lungs. So, it leads to shock and acidosis. And this is not responsive to allotropes. If sometimes, now depends on supportive care. In district places where supportive care is moderate, in those cases, we lose these patients rapidly. Sometimes within 1 hour, 2 hours, sometimes at the most 1 day or 2 days. There are many district places where it has been dictum that all intubated patients are expired in COVID. This is a fact. And metro cities where the monitoring and supportive care is better, only sometimes we postpone the inevitable. That is, after this hypoperfusion event, significant event, almost all organs of the body get actually hypoperfused. And they manifest one by one. We develop oliguria, anuria, we get myocardial ischemia and stroke. And usually these patients, they succumb to renal failure afterwards. They die after a few days. So though they die after a few days, the original insult has happened here. That is systemic hypoperfusion. So if we are able to prevent this, then so many deaths can be prevented. So what are the evidence for that? All these hypotheses we put, but what is the evidence? This evidence we won't discuss in this because we want to keep this purely clinical and physiology. All these other evidence we'll put into part 2, that is next video. But let us recapitulate what are the questions arising in our mind. We should not accept this hypothesis at all, unless and until we're able to answer all questions. Even one question also not answered, then we should not accept this hypothesis. What is the evidence that this vasoconstriction is actually happening at precisely 2.5 millimeter diameter? This question we should ask. We should be able to answer that. Next is, how do we know that local hypoxic pulmonary vasoconstriction is happening at this early stage? This doesn't require evidence because this is a known fact. In any infection or any local atelectasis, we do get hypoxic pulmonary vasoconstriction. This is a defense mechanism. It will divert the blood flow from useless alveoli to useful alveoli as saturation is maintained. That's why majority of pneumonia saturation is normal. So this doesn't require evidence. This is a common knowledge. Next is, what is the proof of widespread pulmonary vasoconstriction? What is the proof? It is a common observation that these COVID patients, their at-rest saturation is 92. If they move around, they talk or they walk, saturation further comes down to 85. So after activity, saturation coming down is first warning sign of presence of pulmonary vasoconstriction. Majority of them on echo, they show pulmonary hypertension, but not all. Because when echo is being done, saturation is maintained. But when they exert, saturation comes down. So it's a dynamic situation. So there is evidence that widespread pulmonary vasoconstriction is happening in COVID. Now here is the problem. How does the sensor handle contractile signal? We gave example of restart, 2 bosses and all those things, but that is only for at least what we can say giving example. But actually why? Why this sensor is actually, instead of getting confused, is following only one boss. This boss, this alveolar O2, is telling to dilate. This boss is telling to constrict. Why this listens to only this, not to this? It's very important because after intubation, suppose saturation is rising but not becoming normal, then whether to increase oxygen or decrease oxygen. This is the turning point. That particular dilemma we'll address in next session. Why does capillary bed accommodate such a large volume? This pulmonary hypertension is common. It is not new. Before COVID also pulmonary hypertension was happening. We didn't come across this sort of complication. Why it is happening specifically in COVID? Why? What is the specificity of COVID that this blood, volume of blood in lung is so huge that is accommodating liters and liters of blood? Why? That particular evidence comes from autopsy findings. In autopsy findings, they have found out interceptive angiogenesis, because of which the capillary bed is expanded so much, cross-sectional area is expanded so much that it can actually accommodate supranormal volumes of blood. That also will be discussed in detail in next session. Next thing comes up. Why does heart develop ventricular dysfunction? Because in pulmonary vasoconstriction, there should be strain on right ventricle. Why it affects left ventricle? That evidence comes from echo. Last is, why does thrombosis follows hypoperfusion or hypoperfusion follows thrombosis? This is very important from therapy point of view, because a lot of studies have come where thrombosis is blamed as a primary. This whole COVID thing is a thrombosis disease. Now, when you go for autopsy finding of these lungs, where is the location of thrombosis and where is the location of vasoconstriction? Vasoconstriction can't be seen in autopsy. Vasoconstriction can be seen only in live patient. Thrombosis can be seen in expired patient. So when we analyze these two facts together, we came to know that actually thrombosis is happening at 1 to 2 millimeter diameter, and this hypoperfusion is happening at 2.5 millimeter diameter. So it appears to be thrombosis to be secondary to hypoperfusion, not primary. So all these details will come into discussion on autopsy. So these are few discussions and physiologies and all those things we saw, but that is only to orient ourselves about what mistakes we have done in our case, what is happening all over the world, and good patient is becoming bad, After intubation, we are not getting sufficient results. So what is the hypothesis here? Hypothesis here is inappropriately high oxygen. Only oxygen is not actually harmful, but inappropriately high oxygen administration leads to shock and worsening gas exchange. Now this inappropriately looks subjective. What are the actually examples of it? When it actually happening? Because we know that oxygen is a savior. We can't blame oxygen. Because of oxygen, these patients are improving. Because of oxygen, water concentration decreasing. And these patients are coming out. Oxygen is must. In almost all cases of COVID, we require oxygen. Must be given in appropriate amount. What is appropriate amount? Appropriate amount we measure in two parameters. One is flow, second is FiO2. In district places, FiO2 is not available. Flow is available. So with flow, we increase and decrease oxygen. When saturation comes down, we increase flow. Saturation goes up, we decrease flow. But this flow is not actually very accurate because FiO2 is unknown here. If FiO2 monitoring is available, it is more accurate. More accurately, we can increase or decrease FiO2. So we'll see what we can do in all levels as far as this titrating this oxygen is concerned. What are the examples where inappropriately high oxygen is being delivered unknowingly, which can actually lead to a lot of worsening? First example I would like to quote is the same example what we did in our own case. This baby was having only tachypnea. This baby was not having much distress, minimal distress, normal saturation. But just is a dictum, it is a habit out of something which is actually inculcated in all caregivers. When patient comes with respiratory, we start oxygen. And this oxygen is given with only flow adjustment, no FiO2 adjustment. This is the commonest mistake. And when saturation jumps to 199, we should be worried, but we were not worried. We should be worried actually. So this 99 and 100 saturation, sudden jump, I'll repeat, there is no saturation which is harmful, no saturation which is helpful. But rapid jump, sudden jump in saturation is the thing in COVID worsening. So this rapid jump will happen when we don't give respect to the saturation numbers. Second thing happens commonly. It is not discussed in conferences and all, but those who have worked in ICUs, they know it very well. When you're on duty in ICU, any sister or doctor, especially in tricky patients, unstable patients, in situation when patient can worsen suddenly, in those at night, FiO2 or oxygen flows are increased very high, just to keep the patient quite stable. To prevent worsening at night, prophylactically, daytime sisters or doctors, they increase the oxygen flow or FiO2, only to find in COVID that 1 or 2 patients can be having actually cardiac arrest in the morning. So this phenomenon has been observed. It is not an imagination. It is happening. So don't do that. So this saturation should be respected. All the sisters and doctors should be oriented. Hyperoxia is hyperoxia. Hypoxia is hypoxia. We want normoxemia. That is too high saturation as well as too low saturation. Both should be discouraged and appropriate oxygen saturation should be maintained. Don't crank up this particular flow or FiO2 just to be safe. By doing that, actually we are being more unsafe in COVID. Before intubation, once we intubate, ventilator is kept ready with predetermined settings. This one I agree because this lung is easy to ventilate. Even if you use less volumes, less pressures, these lungs are very easy. When lungs are easy, we are giving 100% oxygen. 100% FiO2 should not be set in these situations because it doesn't match. This 100% FiO2 recommendation was based on ARDS. And all of us, we know that this is not purely ARDS. It is a combination of diseases. So this before intubation, setting up very high FiO2, 100%, and then trying to come down is not scientific. So before intubation, ventilator is kept ready and settings should be adjusted according to requirement based on chest rise pressures, based on saturation behavior, FiO2. Next is CT scan or suctioning is the time when tubings are disconnected. Suppose patient is on FiO2 of say 40%, 60%. We disconnect and start the bag with reservoir and all. Then suddenly the FiO2 goes to 100%. This rapid increase in FiO2, if it leads to rapid increase in saturation, can also lead to reperfusion flooding of the lung, and that can lead to hypotension. These cases were seen. Now, what are the therapeutic implications of it? We are told the problems, but what is solution? Now, the solution should be able to implement in all levels of care because our country, our world is not uniform. Everywhere, all the gadgets are not available. So how to go about this therapeutic implication depending on your situation? For example, first, these are the color-coded masks, and this is Venturi mask. These color-coded masks are for different FR2 delivery. This Venturi mask is a beautiful way by which we can actually titrate the FR2. And for a particular flow, how much FR2 we can deliver, we can titrate, we can decide, we can regulate. So if it is available, we encourage, this mask should be encouraged. These are used called commonly, but since it's hypoxic nature of COVID, these masks are not being used as regularly as it should be. So this particular Venturi mask, color-coded mask should be brought out of the cupboard and we should start using them so that FR2 we can titrate based on saturation behavior. Given instruction to all healthcare workers that hyperoxia we should avoid and hypoxia also we should avoid. If saturations are going above 95%, reduce the flow. This is possible at all hospitals. Even if you don't have FR2 meter, flow meter is there and we can adjust it. But don't take it literally. It is not possible to keep it below 95 always. So sometimes it is going to go 96, 97, 98, yes. But if it was 90 and now we are given so much, now it has gone to 99, 100, that situation we should avoid. It has to be actually inculcated as a culture, because this culture is already present in NICUs, newborn ICUs, where all the sisters are oriented about the dangers of hyperoxia. When saturation goes above 95, 98, 99, 100, that saturation is harmful. So try to come down realistically. Don't be very accurate that all saturation must be below 95. It is not possible. But don't cause hyperoxia by choice. Allow saturation to rise slowly rather than rapidly. This is the core thing. It is not the number. It is not what saturation is good, not saturation bad, what is the target and all those things. It is the speed. Because as we saw, the pulmonary artery, which is actually constricted completely because of hypoxia, suddenly becomes big if the actually FiO2 increases, that is alveolar oxygen increases. So it is the speed, not the number. So allow saturations to rise slowly. In intubated situation, slowly over a few minutes and hours. In case of non-intubated, over a period of days. Over a period of days, the saturation goes improving. Over a period of minutes and hours, it goes on improving in intubated patients. So allow saturation to rise slowly. Don't try to pull the saturation by giving very high effect. So this particular discussion we discussed physiology, we discussed clinical applications, but one question actually troubles us. When this looks so simple, why it was not known earlier? Why we ended up giving 100% oxygen to COVID and all those things? After intubation, start ventilation with 60% FiO2 rather than 100% FiO2. 100% FiO2, this recommendation is present in COVID protocols since beginning. So we'll see that how it came. Just like neonatal ICUs, staff nurses should be oriented about the concept of saturation targets and flexibility. Here, I would like to repeat again, target is not important, flexibility is important. No one knows actually in the world what should be the oxygen target. So many studies are done and gone. But flexibility is the key. If it is rising rapidly, come down. If it is falling, then go up. This flexibility is the key in managing oxygen. During disconnection from ventilator, AMBU bag without reservoir should be used if saturations are acceptable. Without reservoir means we end up giving less than 100 FR, because these occasions can be actually foundation for next worsening. Now we'll complete the hypothesis. What is the hypothesis here? Or pathogenesis of COVID completely. First is P-type COVID and C-type COVID. C-type COVID is something where Clara cells are affected. With Clara cells affection, it leads to complete collapse of alveolus because surfactant proteins are less. In some cases, we get P-type COVID, that is pneumocyte 2 COVID. Pneumocyte 2s are affected, but they can be replaced by Clara cells. They can multiply. So the collapse is not complete, it's partial. But whatever, partial, complete, C-type, P-type, ultimately it leads to hallmark of COVID, is alveolar collapse. There's no doubt about it. Because we see it on CT, alveolar collapse. Significant alveolar collapse, which is peripheral in nature. Now this alveolar collapse leads to fall in alveolar oxygen. This fall in alveolar oxygen causes trigger of the sensor, and it leads to second part, that is pulmonary vasoconstriction. Widespread. Even if where there is no pneumonia, also there is vasoconstriction happening. Widespread pulmonary vasoconstriction. That leads to hypoxia. Now, this widespread pulmonary vasoconstriction has got effect on heart, because when there is all vasoconstriction going on in lungs, then it is going to affect the heart. Which heart? Right heart. Right heart affection. Right heart affection spreads to left heart also. So biventricular affection. And usually, majority of cases, these patients start recovering slowly. Why they recover? They recover from here. Both these Clara cells and pneumocytes, they are replaced. These pneumocytes especially are replaced. When the pneumocytes start replenishing, surfactant starts forming, alveoli start expanding. When alveoli start expanding, this vasoconstriction slowly comes down. We want this vasoconstriction to come down slowly, not rapidly. Vasoconstriction slowly comes down. Then ventricles start recovering. What is the evidence, clinical picture by which we can say this? Clinically, how can you say this? Clinically, very easy to be bedside is after activity. If the patient's heart rate is going up, then more likely this patient is suffering from some sort of ventricular dysfunction. After activity, the patient's saturation is coming down. That means he's suffering from pulmonary vasoconstriction. And we know that it happens after activity, heart rate goes up and saturation comes down. Sometimes only one thing happens. So by this simple clinical test, in this triangle, where is happening that we can know. That is, after activity, if vital signs are fluctuating, that means the original problem has not settled. So wait, give rest to the patient. And those unfortunate patients, when it doesn't happen, it progresses, then what happens is disaster. Then what happens is that we give inappropriately high oxygen. This inappropriately high oxygen leads to sudden conversion from constriction to dilation, sudden pulmonary vasodilation with flooding, hypoperfusion flooding of lungs. Lungs contain plenty of blood. Now this plenty of blood can't be pumped out by left ventricle because ventricle also is failed. So because of this double problem, there is something which we don't want, that is death. So this death, if we want to prevent, then we have to follow simple precautions, especially as far as oxygen delivery is concerned. So what? We'll see. So when we discuss all those things, why this 100% FiO2 creeped into our protocols? Why these COVID protocols mentioned 100% FiO2 since beginning? For that, we had to go to UK, or Europe, to be specific. In Europe, what happened is that NEGM published one article, like liberal or conservative oxygen therapy for acute respiratory distress syndrome, means ARDS. In ARDS, whether to be liberal or whether to be conservative about oxygen therapy. This was about ARDS. It was not about COVID. And this article compared the two strategies. One strategy is keeping the patient slightly at lower saturation. That is accepting lower saturation, 88 to 92. And second group was very high saturations, 96 or above. And these two groups were compared. Traditionally, our targets are very clear, 88 to 95, or some people take 90 to 95. Some people like this, some people like this. But this is a very comprehensive and widespread acceptance for decades. But out of that, whether to this or this was compared. And it was found that more deaths were happening in low saturation group. After that, the trial was actually stopped after 200 enrollments. Unfortunately, what happened is that this trial was published in March 2020. March 2020, this trial came out. And March 2020 was the time when actually COVID hit Europe. Cases in UK 1st March only 35, 31st March 25,000. So you can imagine a time when we came across a situation where hypoxic respiratory failure is coming up and we get evidence that low saturations are harmful, then naturally we are going to overreact. This study has been quoted as a reference for the protocol of COVID. If you go see the protocol of COVID, you will come across this study only. So this previous study was quoted as evidence that we should give 100% effort. This study did not tell us that 100% effort should be given. But this study told that ARDS patient, not COVID, if they deliberately kept hypoxic, then actually death rate increases. It was true, but that was for ARDS, not for COVID. And certainly they never proposed 100% effort. What happened is that overreaction happened. So we we thought that less than 90% is dangerous. So actually opposite happened. It was double dangerous. That is keeping the patient hyperoxic. So that we have to learn from our past and we have to correct in future. And it's quite easy because all of us, we know that 90 to 95 or 88 to 95 is a standard target in all over the world. In fact, 100% FiO2 is discouraged earlier itself. That because this 100% FiO2 leads to free oxygen radical injury. It leads to atelectasis of lung when you disconnect the ventilator. So we are not suggesting any new thing. We are just going back to the basics, going back to the combined understanding for decades. So what we suggest in this particular session is something which is simple carry-home message. What is simple carry-home message is avoid hypoxia. That is less than 88 to 90. Avoid hyperoxia. Don't allow rapid rise to 9900 and play in between that if possible. Some deviations are going to happen. Some deviations are going to happen. With activity, with walking, talking is going to happen because vasoconstriction is there. But don't voluntarily create hyperoxia. So main thing is after intubation, when you intubate a patient for this particular respiratory failure worsening, never give 100% FiO2, give 60% FiO2 and let the saturation rise slowly and titrate the FiO2 based on saturation. We may have a situation when saturation is borderline, but patient is vasodilate. So don't allow for rapid rise of saturation. Give 60% FiO2 and go step by step rather than going up and trying to come down and having a shock. So after intubation, give 60% FiO2, let the saturation rise slowly. In this session, we covered only clinical parts and physiology, but this is incomplete. This session is incomplete. We should not take it as face value at all. We should ask questions about evidence. So what are the questions we raised about our own hypothesis? We should be able to answer it by autopsy finding or by investigation or by echo. Then only this particular discussion is complete. So that remaining part we are going to cover in next session. So I would like to repeat, in first we covered P-type and C-type COVID. Second we covered cellular basis. Third and onwards we are covering pathogenesis. So as a continuity of this, please see next video where evidence for this hypothesis is given. Thanks.